Bismillah ar-Rahman ar-Rahim. Now we have to start right away because you're short of time. And now we have AstraZeneca Industrial Symposium. And Professor Mohamed Salah will talk to us about CKD. Can we look deeper?
Bismillah ar-Rahman ar-Rahim. Thank you, Mrs. Chairman. Again, we will start the lecture immediately because of the sake of time lag. We'll talk today about chronic kidney disease. Can we look deeper? I would like to thank AstraZeneca for giving me the chance to talk about a subject that I really like, and I think it's the new era in the next few years, the SGLT2 era, and what can we expect of these medications to ameliorate the condition of CKD. The objectives of our talk will be about the outline, the burden of CKD and importance of CKD diagnosis, understanding the totality of evidence regarding dapagliflozin in CKD from prevention to treatment, and translate the evidence to clinical practice to support improvement in patient outcome. Dapagliflozin breadth of cardio and renal outcome data across type 2 diabetes, heart failure, and CKD from prevention to treatment. We have three major studies: the DAPA heart failure, which shows it was the first SGLT2 inhibitor heart failure outcomes trial in patients with heart failure with reduced ejection fraction with and without type 2 diabetes. And it showed reduced the risk of hospitalization due to heart failure and cardiovascular death. The DECLARE study, it was the largest SGLT2 inhibitor trial up to now. In this trial, the patients with type 2 diabetes and cardiovascular disease were studied, and it showed reduced the risk of hospitalization due to heart failure and may prevent new onset or further progression of nephropathy. And DAPA CKD, which is the landmark trial, it's the newest one with the data coming soon, some of them already released, and they are continuing to go further with this study, and it showed marvelous results, as I will show you later. It's the first SGLT2 inhibitor kidney outcomes trial in patients with CKD with and without type 2 diabetes, and that's the importance of this study, again, because it involved also patients without diabetes. And it showed clearly there is reduced risk of chronic CKD, chronic kidney disease, progression, and stage kidney disease, and renal and cardiovascular death. Dapagliflozin offers patients protection from serious cardio and renal outcomes associated with the three interrelated diseases, which are the CKD, heart failure, and diabetes. Dapagliflozin indicated in adults for treatment of symptomatic chronic heart failure with reduced ejection fraction, and it is indicated in adults for the treatment of insufficiently controlled type 2 diabetes as an adjunct to diet and exercise, as monotherapy when metformin is considered inappropriate owing to intolerance, or in addition to other medical products for the treatment of type 2 diabetes. And the new indication is the treatment for CKD in adult patients with estimated GFR above 25 milliliter per minute per 0.73 square meter. DAPA is proven to reduce the risk of the composite of declining kidney function and stage kidney disease and renal or cardiovascular death. It's indicated for symptomatic heart failure, patients with reduced ejection fraction or CKD in adults with and without type 2 diabetes. So, what clinical goals do you want to achieve for these patients with diabetes, heart failure, CKD? As we all know that CKD represents an enormous healthcare burden affecting almost 10% of the world's population, 10 to 11% of the world population. Meta-analysis estimating the global prevalence of CKD stage 3 to 5 showed clearly that it ranges between 5 up to 15% in some countries in the world. Unfortunately, we still doesn't have very accurate data here in Egypt. I know Professor May is doing great effort now for the registry, and hopefully we'll have such registry soon. But we are comparing ourselves with the surrounding countries, so we expect to have somewhere between 7 to 10% of the population, which means around 10 million Egyptians having some degree of chronic kidney disease. So we're talking about a huge burden on the healthcare system. And of course, with the ongoing presidential campaign now, where they are screening for early detection for CKD, I think we will have a very good estimate in the near future. CKD has diverse etiologies, the majority of which are non-diabetic in origin. As we all know, diabetes and hypertension together represent somewhere around 60% of all patients with CKD, where diabetes comprises around 42% of patients, and hypertension 18% of patients. The other is ranging between glomerulonephritis and some other causes for CKD, hereditary and so forth. 58% of CKD cases are non-diabetic, if you look at it on the other way from the coin. Despite CKD affecting many people and resulting in poor outcomes, it remains underdiagnosed. As you can see, heart population, patients with heart diseases are betterly managed than our patients. Maybe because the heart is not a silent disease as we have in our patients. Usually, most of our patients present to our clinics in late stage because they don't feel anything till becoming a bit uremic. Unlike the heart patient who, whether heart failure or coronary heart disease or whatever, it is a rather annoying disease that push the patient to seek medical advice as early as possible. Diabetes patients also have a better coverage than our patients for the same reason. So only 10% of our patients are detected and they seek medical advice early. The cardiac and renal systems are linked, so a disorder in one of them will affect the other in a very close and intimate manner. Diabetes and or hypertension usually leads to activation of the RAS system, where neurohormonal activation occurs, inflammation, endothelial dysfunction, ischemia, fibrosis, oxidative stresses, and the cascade starts, and it's a vicious circle. It affects heart, causing heart failure, and the kidney, causing CKD. And again, it's vice versa. Each of them will affect the other. Life expectancy in adults with early stage CKD is 5 to 6 years shorter than in adults without early stage CKD. So it has a burden also on the life span. Declining kidney function results in dramatic increase in rates of cardiovascular events, hospitalization, and mortality, as shown here in these graphs. the cardiovascular events, hospitalization, and rates increase gradually with decline of the estimated GFR. Patients with CKD are more likely to die than develop end-stage kidney disease. They die before reaching the end-stage point. Rates of end-stage kidney disease and mortality among patients with CKD, the end-stage kidney disease at onset compared to those due to cardiovascular mortality and non-cardiovascular mortality are shown here. So you can see that the least is death due to end-stage kidney disease, while cardiovascular and non-cardiovascular causes are, for mortality are much higher than due to end-stage disease, probably because they don't live before to reach the point of death from end-stage kidney disease. The loss in life expectancy due to cardiovascular disease is more dramatic with declining kidney function. So as you can see in this diagram, the more the decline, the more in the estimated GFR, the more the expected cardiovascular disease and events to happen, and life expectancy becomes shorter with the reduction of the estimated GFR, due to not only because, as we mentioned before, due to the end stage or due to kidney causes, but due to also the end stage kidney disease, or the reduction in the estimated GFR also increased the chance of getting cardiovascular disease and death from cardiovascular disease with declining in the GFR. We all know that chronic kidney disease is a state of inflammatory condition, calcification increase almost 50 times the normal population, ischemic heart disease, coronary vascular disease, and all these diseases are linked and much more increase with the reduction of the estimated GFR. So the number of life years lost due to cardiovascular disease increases with severity of CKD. How are you prioritizing management of your patients at risk for CKD progression? This is a model, Mr. Samir, patient at risk of CKD progression to end-stage kidney disease, heart failure, and death. Why? Because he has reduced estimated GFR around 35 milliliter per minute, albumin creatinine ratio, urinary albumin creatinine ratio 220 milligram per gram, treatment receiving maximum tolerated dose of RAS inhibitor therapy, hypertensive, and but he is, fortunately, he does not have type 2 diabetes. We're all familiar with this graph, which plots the progression of kidney damage with the urine albumin creatinine ratio against the declining in the GFR, and it shows the degrees and the risk, so forth. According to the data I presented the slide before, Mr. Samir happens to be in this zone where he is in a high risk for developing cardiovascular and renal problems according to his condition. So, the current medications leave significant risk of disease progression. According to the renal, which is a risk of decreased serum creatinine, end-stage kidney disease or death with placebo versus losartan in patients with type 2 and type 2 diabetes and nephropathy, you can see that still against time, the condition, though a bit slowed down, but still going on. We cannot stop the process. It will go on and go on inevitably, whatever we did to stop the process. And still there is a significant residual risk after using the angiotensin receptor blocker. There is a need for novel therapies to improve the life and outcomes of patients with CKD. So CKD represents a significant unmet medical need. Diagnosis rates must improve and novel management approaches are required. CKD is an enormous global healthcare burden. CKD is associated with cardiovascular, cardiorenal morbidity and mortality, and there is a need for a new therapy in CKD. Dapagliflozin has demonstrated cardio and renal benefits across spectrum of CKD. Estimated GFR should be above 25 milliliter per minute up till now, because they are working on lower GFRs, and soon they will release the data that you can use it below this. And I know many of us actually go below the 25 milliliter per minute, but cautiously. Dapagliflozin, the first therapy indicated for the treatment of CKD with and without type 2 diabetes in the last 20 years. Actually, we never had a medication that we intend to treat. We usually give the medications in CKD to try to halt or reduce the rate of progression. This is the first time we are talking about a medication that we are intending to treat. So that's revolutionary, in my opinion. Dapagliflozin clinical program spans prevention to treatment in CKD. You can see here that the mean estimated GFR and median urea albumin creatinine urine albumin creatinine ratio values are at the baseline. Forxiga is not recommended in patients on dialysis, برضو مهمة, and should not be initiated in patients with estimated GFR below 25 milliliter per minute. The landmark DABA CKD trial included a diverse study population representative of patients you see in your practice. Those with estimated GFR somewhere around 25 to 75 milliliter per minute, urine albumin creatinine ratio between 200 to 5,000 milligram per gram, mean blood pressure 137 over 78 millimeter mercury, and 97% of the patients received ACE inhibitors or ARBs therapy to maximize to the maximum tolerated dose. 30% were without type 2 diabetes, and 68% were having type 2 diabetes. The primary endpoint, it's a composite of sustained reduction of the increase, of the GFR, more than 50% reduction of the GFR, and end-stage kidney disease and renal or cardiovascular death. So you have to have a sustained reduction of the GFR more than 50%, or reaching end-stage kidney disease and renal or cardiovascular death. Again, back to Mr. Samir, we mentioned that he is at risk, and the patient falls in this group, in this study. It's the same study. He is one of the patients who were included, of course, with another name, but this is a nickname. Patients in DABA CKD had a broad range of etiologies. Investigator reported causes of kidney disease, and they found that, again, 58% of those in the study were due to diabetic nephropathy, 16% glomerulonephritis, 16% hypertensive nephrosclerosis, and almost 10% other causes. They included one of the largest cohorts of patients with IgA nephropathy, and this is an important one I want to highlight, and I will talk about it later. In any clinical trial to date, 17% of patients without type 2 diabetes had IgA nephropathy at baseline. Etiology of CKD, as shown here, in overall population of the study, 58% and 16 and 16, as I mentioned. For those who were diabetics, 86% of them were having CKD due to type 2 diabetes, and 7% ischemic hypertensive nephropathy. For the non-diabetics, 35% were ischemic hypertensive nephropathy, 42% due to chronic GN. Dapagliflozin significantly reduced the risk of the primary composite outcome in DAPA CKD. You can see there is 39%, of course, relative risk reduction, and the absolute risk reduction was almost 5.3%, which is also a great deal of response. Dapagliflozin reduced the risk significantly by 50% of the primary composite endpoint in patients without type 2 diabetes. Again, it's a relative risk reduction improvement, 50%. and absolute risk reduction around 5.4. Dapagliflozin showed consistent efficacy across a broad range of patient subgroups versus placebo, and you can see here that the hazard is always in favor of DABA patients who receive the dapagliflozin. Exploratory composite outcome, chronic dialysis, kidney transplantation, or renal death also showed 34% relative risk reduction or 1.5% absolute risk reduction. And changes in albuminuria in the overall population also, there was 42, almost 43% reduction with dapagliflozin versus placebo. In patients with CKD with or without type 2 DAPA-CKD, secondary endpoint showed also the all-cause mortality was reduced by 30% relative risk ratio and 2% absolute risk ratio. Changes in albuminuria in the overall population, sorry, this is the previous slide. In patients with CKD with or without type 2 diabetes also, we found 25% reduction in cardiovascular death or hospitalization due to heart failure versus placebo. Consistent benefit was observed for the primary outcome, cardiovascular death or hospitalization due to heart failure, and all-cause mortality in patients with CKD stages 2, 3, and 4. As you can see here, again, the that all the results are in favor of DAPA-CKD. Further exploring the effect of dapagliflozin by causes of kidney will show us that the IgA nephropathy group, the number of patients participating in this group with IgA nephropathy in clinical trials, the DAPA-CKD has 270 patients, and those patients showed 71% relative risk ratio reduction in the primary composite endpoint versus placebo for those who were kept on dapagliflozin. Dapagliflozin offers a complementary pathway to RAS inhibition to lower intraglomerular pressure and protect nephrons. The primary dapagliflozin mechanism for preserving kidney function is not dependent on the blood glucose lowering effect and is not limited to patients with type 2 diabetes. Safety and tolerability of dapagliflozin were studied in patients with CKD with or without type 2 diabetes here, and you can see that the safety concerns are significantly statistically non-significant between placebo and dapagliflozin's patients, especially as regarding amputation and recurrent UTI, which were the major concerns at the beginning of using the dapagliflozin. They showed that it was not statistically significant at all. Dapagliflozin is the first approved therapy to advance the treatment of patients with CKD with or without type 2 diabetes in over 20 years. As I mentioned, the results of the study, of course, there is contraindications for using it, which have prior serious hypersensitivity reactions, and those who are up till now with estimated GFR below 25 milliliter per minute, patients with kidney transplant not yet approved as well to be used up to now. So to conclude, dapagliflozin offers a simple dosing and administration, which is 10 milligram per day for those above 25 milliliter per minute. If you initiate it above 25 milliliter per minute, and for some time the patient may go below the 25 milliliter per minute, keep the patient on the medication. Do not shift or change unless if you have sustained reduction of the GFR, and you may not start it below 25 milliliter per minute and not in diabetic and in transplant patient. And of course, it is safely used in non-diabetic patients. It does not cause hypoglycemia if the patient was not diabetic. So it's safely to be used. And of course, it causes some weight reduction, which is also a benefit that our patients might need sometimes. Thank you.
Thank you, Professor Mohamed, for highlighting the importance of dapagliflozin. And actually, it is an important weapon that we can add on to our existing ACE and ARBs. And of course, it really is of importance not only for the kidney, but also for the heart.
Sure.
Now, let me please come here to give you a present. Thank you very much. Now we have a light lunch and we'll be back for the opening ceremony at 5. Okay? Exactly 5, inshallah.